Medicare's 65 decision is a fork. Your doctor's travel and bill can change with the branch. Pick the wrong branch and the problem may not appear until the appointment is booked. Hold on to one open loop. There's a 6-month protection window around Medigap, and it doesn't come back every year. I'll show you exactly where Part B fits before we close.
The version going around says Medicare Advantage is just original Medicare with a nicer commercial. Half true. They both must cover medically necessary original Medicare services, but the plan rules around networks, referrals, and approvals can be very different. Tiffany tests the headline before it tests the viewer.
And the other version says original Medicare is automatically the expensive option. Also half true. The premium isn't the whole bill. You've got to price the supplement, drug coverage, doctors, and the places you actually use care.
Start with the vocabulary. Original Medicare means Part A and Part B administered by the federal program. Medicare Advantage, also called Part C, is a private plan that delivers your Medicare coverage under its own network and cost rules. Medigap is supplemental insurance for original Medicare. It isn't a third branch that can sit beside Advantage.
That last sentence is the red flag. You can't buy Medigap to cover an Advantage plan's copayments, deductibles, or premiums. If a sales pitch makes those sound interchangeable, pause the application.
I would write the decision as 3 lines: which doctors must stay in network, whether prescriptions are included, and what happens when you travel outside your service area. If you can't answer those, you're not comparing plans yet. You're comparing colors.
Take Darlene, a composite example, 66, 2 specialists in different states, and a winter trip every year. Her best answer isn't determined by a headline about a $0 premium. It turns on whether those doctors take the plan, whether the plan's service area follows her, and whether a Medigap policy would make original Medicare's cost-sharing predictable.
Darlene's question is the viewer question too. Can I keep my doctor and still protect myself from a big bill? That's the comparison we're going to make, not a popularity contest between insurance logos.
Coming up, we'll put both branches on one board and expose the rule that changes your bill. Quick honest ask while we are here. If this has been worth your time so far, hit like, then subscribe and ring the bell. I know everyone asks, but this one is free, and it is how a small channel like this actually grows. Let's put the comparison where it belongs, next to each other, not buried in 2 separate brochures.
Original Medicare's big advantage is geographic freedom. Medicare.gov says you can use any doctor or hospital that takes Medicare anywhere in the United States. That is not a promise that every provider accepts every billing arrangement, but it is a very different starting point from a network.
In Advantage, the first click is not "Is this doctor good?" It is this doctor in the plan's network and service area? Some plans cover out-of-network care, often at a higher cost. The network is part of the insurance product.
Now the cost line. Original Medicare usually leaves you paying 20% of the Medicare-approved amount for Part B covered services after the deductible. Medicare Advantage costs vary by plan, but the plan has a yearly limit for covered Medicare services. Neither sentence tells you which is cheaper until you plug in your care. Before we get to the dates, hold on to this comparison.
I disagree with the idea that bundled means better. Usually bundled is doing honest work, but it does not mean every plan has identical drug coverage. Most Advantage plans include Part D, so compare the formulary and pharmacy network instead of assuming the bundle wins.
The comparison is strongest when you treat the network and the annual limit as separate questions. A plan can have an attractive limit and still be a poor fit if your specialist is outside the service area.
Tiffany starts with the network. I start with the yearly limit when someone has chronic care. Erica's synthesis is the useful answer. Check the doctors first, then price the limit against the care you actually use. And prior authorization isn't a moral judgment. It's a plan rule that may require approval before a service or drug is covered. Original Medicare usually doesn't require approval for most covered services and supplies. The practical move is to ask the plan, in writing, what needs approval before the appointment.
The official page is useful because it shows the fork without asking you to trust our adjectives. On Medicare.gov, use the Plan Finder link after you write down your doctor's prescriptions and travel pattern.
True, half true, busted. A $0 premium is not a $0 health plan. It is one line in a plan with networks, copays, approvals, and an annual limit. Read the rest of the page.
Before you click Enroll, ask one body question. Which doctor must stay in network? Then call every must-keep doctor and ask for the exact plan name, not just the insurer name. 2 plans from the same company can have different networks. That's a 10-minute check with a very long half-life.
That is the practical fork. The network changes who you can see, and the yearly limit changes how far the bill can run. Now carry those 2 checks into the enrollment dates. Here's the part people discover while trying to change plans. Medigap isn't an annual coupon. It's a one-time window when federal rules give you the strongest shopping position.
The base is simple. You generally need original Medicare Part A and Part B to buy Medigap. A Medigap policy helps pay your share of covered original Medicare costs. It doesn't replace the Medicare card, and it doesn't sit on top of Advantage.
The internet version says you can buy Medigap later whenever you feel like it, busted as a national rule. Medicare.gov says the best time is the 6-month period that starts when you're 65 or older and enrolled in Part B. During that window, health problems generally can't be used to refuse the policy.
That is why Part B is the hinge. If employer coverage delayed your Part B, your Medigap open enrollment period starts when Part B starts, not when you first turn 65. That distinction is small on paper and enormous in a real enrollment calendar. Michael, keep that date visible.
And if you're applying for Part B in one of the situations that uses a paper application, the form has a name, CMS 40 billion. It's titled Application for Enrollment in Medicare Part B, and it's for people who have Medicare Part A but not Part B. Employer coverage can also bring in CMS L564, the Employment Information Form.
Do not download a random form from a benefits ad. The official CMS copy tells you who can use it, when to use it, and what employment proof may be needed. That is the difference between a document and a plan.
If you leave Advantage and want original Medicare with Medigap, timing and guaranteed issue rights can depend on why the coverage ended. Tiffany, save the notice. Save the denial. Call your state health insurance assistance program or Medicare before you cancel something based on a sales promise.
The action list is short. Mark the Part B effective date, compare Medigap during the 6-month window, and keep every coverage letter. Those records matter if the path later depends on a special right.
Medicare.gov's Medigap timing page makes the federal rule concrete. The strongest window starts when you're 65 or older and signed up for Part B. State law can add opportunities, so check both the federal page and your state.
Part B date first. The calendar follows.
The calendar is the anchor. Part B starts the window, and the window shapes your strongest Medigap choice. Professor Iwata is back with us for the written decision. Let's turn the fork into a choice you can defend.
If your doctors are local, your prescriptions are stable, and an annual plan limit matters most. Advantage may fit. If you travel, want broad provider choice, and can price a supplement and separate drug plan, original Medicare may fit better. Neither branch wins in the abstract.
Write 4 columns tonight: doctors, drugs, travel, and money. Put the exact doctor names in the first column, not just the clinic. Put the exact prescriptions in the second. Then call the plan and ask the network and approval questions out loud.
And put dates in a 5th line: Part B effective date, Medigap open enrollment start, and any employer coverage end date. Tiffany's phrase is right. The premium headline isn't the decision, the calendar is.
If you already have a plan, do not cancel first and ask questions later. Confirm the replacement coverage start date, prescriptions, doctors, and whether a guaranteed issue right applies. Get the answer in writing when you can.
The safest comparison is the one you can explain back: who treats you, what you take, where you travel, and what the plan asks you to approve. If one answer is missing, the choice isn't finished.
Professor Iwata, thank you for making the trade-off concrete. A decision is safer when you can explain the network, the bill, and the date without reaching for the ad.
The system is complicated. Your next move doesn't have to be. Your anchor is the care pattern, not the premium headline. 4 columns, 1 official comparison page, and 1 calendar. Send this to the person who keeps a doctor list in 3 different places.
Michael, check the exact plan name before you enroll. If this helped, subscribe so the next benefits decision arrives before the deadline does. The question to carry forward is simple. Which Medicare branch fits the way you actually use care? Which Medicare branch fits the way you actually use care? Remember the Medicare fork: doctors, drugs, travel, and the Part B calendar. Keep the paperwork, check the doctors, and take care. I will see you in the next guide.